All right, well, good afternoon, everybody. Thanks for taking the time to log in and join us this afternoon. We've got Dr. Patricia Chavez joining us. Dr. Chavez is one of our local advanced heart failure and transplant cardiologists, a new member of the faculty within our group. And she's going to be talking to us about exercise testing and heart failure. So, Patricia, thanks again for putting this together, and looking forward to hearing what you have to say.
Thank you so much for having me. So we will jump quickly into the topic, and hopefully over the next 30 minutes, you can know everything there is about exercise testing and heart failure. Very good. So let's see. So we're going to talk today about functional capacity and how we came to decide that that was something we needed to assess in heart failure, and the ways of examining this particular topic by means of the New York Heart Association classification, the 6-minute walk testing, and cardiopulmonary stress testing. So let's talk about functional capacity. So functional capacity is a term that has been used interchangeably with other terms that you may be familiar with, such as fitness, performance, tolerance, aerobic power, and endurance. And although they may not mean exactly the same, they are closely related to what the goal is for a physician to assess the impact of a disease. Functional capacity in itself is the ability of an individual to be able to carry out daily activities that include things like walking or using the bathroom at home, moving around, going out and about for grocery shopping. But the only way to objectively quantify it is through cardiopulmonary stress testing, which would be the gold standard way of doing this. And why is it important? And specifically, why is it important when somebody has a chronic disease to see where they are in terms of their functional capacity? The reason is because it can affect their ability to live and their participation in society. Chronic disease can affect the activity levels, which are linked to body structures and functions. Being the disordered the chronic disorders such as heart failure that affects those organs. It can affect their participation, as I said, in society, and this can play a role with different environments that the individual has to participate, but it can also be impacted by personal decisions. So then how do we assess this? So in heart failure, we can do this assessment based on three different ways. There's a self-assessment that we know as the New York Heart Association classification, which is a language that we as doctors can easily understand, although it's subjective for most of it. Submaximal stress exercise testing, which is done by the 6-minute walk testing, and maximal exercise testing, which is done by cardiopulmonary stress testing. So let's talk about the New York Heart Association. So this is just a simple way to describe what an individual can do on a regular basis. And its inception happened around in the 1920s, when there was a paper published by Dudley and Smith and JAMA that attempted to describe how could we characterize heart failure or heart disease. And they tried to involve three different domains, being structure, functionality, and etiology. And within functionality, they considered this classification that was suggested by the New York Association of Cardiac Clinics, which since the beginning reflects what we know now as the New York Heart Association class. So they had 4 groups, A, B, C, and D, which pretty much match what we know now for this classification. Over the course of the years, there have been some variations in terms of terminology and more specific details of how we can speak this language across different providers. But it was in 1994 that the classification finally has its last review, so to speak, and this is what we use now. So this classification can assess the severity of heart failure based on their functional status. And this is all by reported symptoms. And the symptoms that we're looking for are fatigue, palpitations, chest pain, dyspnea, or syncope. If we classify as somebody New York Heart Association class 1, if they have no symptoms and they can perform normal activities. Class 2, if they have mild symptoms and they're comfortably at rest, but then they may have some slight limitation in their functional status. Class 3, if they have moderate symptoms, and they're comfortable only at rest, but then have impairment with activity. And class 4, when they have severe symptoms and they even have symptoms at rest. So if you ask a patient to report this, so it's going to be very clear when they have no symptoms compared to when they have severe symptoms. But there's a little bit of like uncertainty when they can describe mild symptoms versus moderate symptoms. And this can also, we have to also take into account what the provider is going to consider something as normal or abnormal. So this New York Heart Association classification, even though, as I said, it's subjective, it's an easy way to assess. And it actually has been included in the guidelines over the years. And as a matter of fact, if you remember, ICD is recommended as a class 1 indication for primary prevention in those patients that have a New York Heart Association class 2 or 3. That obviously have a low ejection fraction, but it's not recommended for those that have New York Heart Association class 4. A CRTD is also recommended as a class 1 indications in suitable patients that have a New York Heart class 2 or 3 or ambulatory and class 4 patients, but is not indicated in those who have a class 1. So the difference is in the interpretation, both from what the patients refer to us and what the provider can make out of it can impact the therapeutic interventions. So let's talk about another way of assessing functional status. So 6-minute walk testing. So 6-minute walk testing, it started probably in the 1950s when there was the first research publication that observed exercise testing in patients. And about 5-6 years later, they decided to reduce the amount of the length of the distance that patients were examined for to 15 minutes and down to 12 and see if there was reproducibility in that. But it wasn't until 1982 when then they decided to even shorten it more because it would take time for the providers to do these tests on patients. And then they broke it down to 6 minutes versus 2 minutes. And they saw that the 6-minute walk testing would reflect and correlate with longer distances versus a 2-minute only. So that's when it kind of settled the idea that this time was enough to assess functional capacity. So, and 3 years later, this testing was introduced to being explored in respiratory diseases like COPD. Finally, in 1986, it was used in patients with heart failure and other chronic disorders. But it wasn't until 2002 that 6-minute walk testing made it to any guidelines. And it wasn't particularly the cardiac guidelines, but the thoracic guidelines. So as I stated before, this is submaximal testing, as we reviewed earlier, but it only complements what the ability of a cardiopulmonary stress testing, which is the maximal testing, exercise testing that we can do. It doesn't replace it, but it can be useful. So we use the distance walk in 6 minutes at a self-selected pace on a hard surface. It looks into the activity limitation domain versus what CPID actually looks for, which is molecular or respiratory limitation domains. In healthy adults, the range considered normal goes from 400 to 700 meters, and it can be useful in the assessment of other diseases such as musculoskeletal disorders, neuromuscular disorders, metabolic disorders. Excuse me. I'm sorry. Excuse me one second. Sorry about that. Let's go. And as I said, this information is just going to complement what we can obtain from cardiopulmonary stress testing. So the methodology of 6-minute walk testing actually is going to have an impact on how the test outcome will be and what it will tell the provider, what it would mean for the provider. So here, for example, this is a nice paper that was published in 2014, where you can see that variations in methodology are going to affect the results of a 6-minute walk test. Something as simple as walking in a hallway versus a treadmill can increase the can decrease the amount of decrease the distance that the patients will actually walk. Indoors versus outdoors will impact the distance that the patients will walk. They work 4 meters more being outside compared to being inside. Walking in a circular track, the length of the track, if they have a wheelchair, or if they have if they have a wheel walking aid, if they have oxygen versus not oxygen, which seems obvious, but patients with oxygen will walk up to 59 meters more. If the patient carries the oxygen versus the tester carrying the oxygen, there will be a 35-meter improvement if the tester carries the oxygen. And more, what I thought was remarkable is that encouragement alone from the provider. So just to tell them, yes, keep going, you're doing a great job, will have an impact of 30 meters in the final distance measured. So when is 6-minute walk testing contraindicated? So there's absolute contraindications and there are relative contraindications. And the absolute contraindications have to do with acute situations, acute MI, acute myocarditis, decompensated heart failure, or mental impairment leading to the inability to actually cooperate with the testing. And relative contraindications are if they have a high resting heart rate or if their blood pressure is uncontrolled, but chronically uncontrolled. 6-minute walk testing has been used in the guidelines. And as I mentioned earlier, it has a very important role when it comes to respiratory diseases. It can be used as a marker for improvement in lung transplantation or any kind of surgical intervention for the lung, but it's also used for pulmonary hypertension. And it can assess functional status, as I said, not only of heart failure, but other diseases such as peripheral vascular disease, fibromyalgia, cystic fibrosis, and COPD. What is the correlation of 6-minute walk testing with the New York Heart Association? So there's no precise correlation. And as I mentioned before, it's easy to see the difference because it's just striking from comparing patients with a New York Heart Association Class 1 versus a New York Heart Association Class 4. Because the New York Heart Association Class 1, they will be able to walk a good distance versus the ones that have symptoms at rest, they probably won't do much. But there's a lot of overlap between the Class 2 and the Class 3 patients, even in the distance that they have to walk, not even considering all the variations in methodology that we just mentioned. And just to put this visually, this is what a Class 1 patient would walk, which is roughly 400 meters. So it's the third track on this running track versus what a Class 4 patient would do, which is just 200 meters. So you can see in perspective that, yes, this is obvious, but if you have a Class 2 versus Class 3 patient, you might not be able to tell the difference apart that easily. So the correlation is not the best when it comes to differentiating Class 2 versus Class 3. What about the correlation with CPET and the prognostic value of using 6-minute walk testing? So this study was published in 2009, and it looked at roughly 250 patients, most of which had heart failure with reduced ejection fraction. However, the ejection fraction was considered low when it was below 50 only. And on average, I would say that they were both, I mean, all the patients had a New York Heart Association class 2. So when you correlate peak VO2 versus 6-minute walk testing, the correlation is not perfect, but there might be some value of comparing these numbers. But if you try to use any of the other variables of CPET and 6-minute walk testing towards prognostication of mortality, then the 6-minute walk testing actually drops from the analysis, and it has no value prognosticating anything. It's really the VVCO2 slope, which we'll talk about it later, and the oscillatory ventilation issues that can have a prognostic value in mortality. So let's talk now about cardiopulmonary stress testing. So in order for us to talk about CPET, we need to have a basic understanding of what happens during exercise. So if we go here from the left, when you're exercising and breathing, so the way I like to think of this is you have to look at the efficiency. How efficient is your heart working with your lungs? So you inhale, and then you bring this oxygen to your pulmonary circulation, which is going to go into your peripheral circulation, and then finally be delivered to your muscle. And at the level of the mitochondria, what you're going to do is you're going to produce ATP. And by that, and CO2. So the CO2 will return to your peripheral circulation, will go through your heart, through the RV, go to the pulmonary circulation again, and you'll exhale the CO2, and then you'll take back more oxygen. So during this process, what are the responses physiologically at the level of these organs? So in the in the muscles, your oxygen extraction will increase, so your production of CO2 will increase as well. And you should not be retaining any CO2, correct? At the level of the peripheral circulation, there will be vasodilation and recruitment. At the level of the heart, your heart rate will increase, and so will your stroke volume, because you just need to pump faster. At the level of the pulmonary circulation, you will also have recruitment and dilation. And at the level of your lungs, you'll increase your tidal volumes and your frequency, your respiratory rate, so you can keep up with what you need to pump. So if we put this into a formula, what does that mean? That your VO2, your oxygen consumption, and what you will need, what you will use, will be dependent on your heart rate, your stroke volume, and the arteriovenous difference, your level of extraction when you're exercising. And this can be affected by many things. Your heart rate can be affected by sinus node dysfunction, by drugs that cause chronotropic incompetence. Your stroke volume will be affected by something like a cardiomyopathy because of contractility issues. Your AV difference will be could be affected by your hemoglobin or a baseline low O2 at an arterial level, by your pulmonary capacity, and the oxygen extraction will be affected by skeletal muscle issues, for example, or peripheral vascular issues as well. Now that we know a little bit about the physiology, how did we come to assess this? So in 1895, it was there's evidence that the first cycle ergometer was created to assess exercise capacity. And in 1958, the first sort of incipient CPET protocol came to light in the research community. Between the 60s and the 70s, there were some modifications, but it wasn't until 1987 that the proper cardiopulmonary stress testing protocol came in the known to the medical community. And this was specifically utilized in patients with respiratory issues and heart disease. And it was in 2012 that it finally was implemented in guidelines as of requirements from this test to make therapeutic interventions. So what is this test and why do we do it? It is a dynamic, non-invasive assessment of the cardiopulmonary system, both at rest and during exercise, and is used to determine an objective functional capacity of the individual. And any deficiencies or any abnormalities that we see in the variables that the cardiopulmonary stress testing can provide can actually prognosticate mortality in chronic diseases and also surgical outcomes. So how is it performed? So there is 3 different protocols that we can use, but the one that we're going to focus on is the one that we use in heart failure, which is the incremental load, which means that the progression of the workload over time will be linear. What are the contraindications of cardiopulmonary stress testing? So there's absolute contraindications that have to do also with acute ongoing issues like unstable angina or recent MI within 2 days, for example, uncontrolled arrhythmia, symptomatic severe aortic stenosis, acute PEs, myocarditis, and there's relative contraindications that have to do with moderate valvular disease, HCM, arrhythmias, or severe coronary disease or untreated PH. And where are the indications? Well, as a class 1 indication is used to evaluate exercise capacity in patients with heart failure or that need consideration for heart transplantation. It can also be used just as assessing exertional dyspnea of an unclear cause. If you have excluded everything else and you still don't have an answer, then it can be used for that. And unfortunately, it's underutilized for that reason. A class 2A indication when subjective estimates are unreliable, and a class 2B indication to evaluate the response to maybe any intervention that it's done where it's important to measure the exercise tolerance as an endpoint. So this is how we will see the results of cardiopulmonary stress testing. And this is known as the Wasserman 9-panel plot. So we have to learn how to interpret this because this gives all the information to differentiate what is the reason for the dyspnea, what's causing the problem here. So this is a tool for that. And we will go over each of these graphs as we go through the cases, but briefly we can mention a couple of things. So that have to do with the normal exercise physiology. So the normal response to exercise has to do that the oxygen consumption is going to be linear. So this is a linear incremental protocol that matches the response of the VO2. So the oxygen consumption goes up as you go for a longer period of time during the test. The heart rate response is also linear and it's parallel to that oxygen consumption. The stroke volume, however, will reach at its max point some sort of plateau where it has a limit to how much you can increase it. And AV difference of oxygen will widen because the venous oxygen will fall as you are extracting more oxygen by the organs during exercise. So what happens in heart failure? So the response to exercise in heart failure is impaired. One, there is a reduced peak oxygen consumption that is derived from, among other things that are obvious, such as decreased stroke volume or chronotropic incompetence by peripheral dysfunction. There will be an early onset of anaerobic threshold. So you switch from aerobic to anaerobic exercise really fast because that's just how much effort you're trying to do to be able to continue. The heart rate response jumps very quickly into the linear slope, and that is an abnormal result, unless they have chronotropic incompetence, maybe from extreme beta blocking. The heart rate at recovery, after recovery, it will have an abnormal recovery. There is an early metabolic acidosis because the CO2, the extraction, the extraction of oxygen is impaired by not being able to reach the muscles properly. So the CO2, you will require you require little oxygen to make a lot of CO2. There is oscillatory ventilation, which this would be similar to the clinical finding of Cheyne-Stokes. Like this breathing pattern that heart failure patients can have can be reflected in this oscillatory ventilation. There will be a low O2 pulse, which is the oxygen consumption over heart rate, because the stroke volume augmentation is limited in heart failure. But typically, you're not going to see a desaturation at an arterial level unless there's additional pulmonary disease. Other factors that can affect the response to exercise in heart failure are reduced inotropic and chronotropic response. If there's, worse dynamic or severe MR, peripheral dysfunction, and if they also have muscle abnormalities. So how can cardiopulmonary testing predict mortality in heart failure? So the landmark study that showed this was published by Dr. Mancini in 1991. And what we can see here is that this is where this peak VO2 of 14 comes. So patients that had a peak VO2 for transplant and then under 14 and then were referred to transplant had a better survival than those that were not referred to transplant. And patients that had a peak VO2 over 14 had an overall better survival than all of them. And this paper even showed that when the peak VO2 was under 10, they had the worst outcome of all of them. And this has prevailed over time. This study published in 2023 looked at even lower thresholds of peak VO2 as isolated numbers. So we see that the group 1 here in blue had a peak VO2 under 8, and we will see that the survival is the worst compared to the 3 curves. The group 2 that had a peak VO2 between 8 and 10 had a similar survival curve compared to the first group. And then the group 3 that have a peak VO2 under 10 had a better survival compared to the lower peak VO2 groups. And as the years have gone by, we know that this, as I said, these findings are still there. So if the lower you peak VO2, the higher your mortality probability. What other predictors can we use for mortality when we come to analyze cardiopulmonary stress testing? So we can use the VVCO2 slope, which is normal under 34 in a dimensionless report, no units. There's increased ventilatory effort in heart failure, and there's going to be the onset of anaerobic threshold is going to be early, as we said. So we're going to switch from aerobic to anaerobic exercise very early on in patients with heart failure. But we also have to take into account that the peak VO2 will decline with age, and it's actually lower also in women, that there's need to be adjustment when there's obesity to the ideal body weight, and that a lot of our patients are on beta blockers, and we need to take that into account. And last but not least, we can expand the use of CPET in patients with HFpEF, not just with reduced ejection fraction. So do we have a classification out of this test that can help us? Yes, and this is the Weber classification, which uses 5 categories based on VO2 max and the anaerobic threshold. And it goes from mild, moderate, moderate to severe, severe, and very severe if the VO2 max is extremely low, under 6. And has CPAP been included in the guidelines? And yes, the answer is yes. So advanced heart failure is defined per CPAP parameters as a VO2, as a peak VO2 under 12 or under 14 if the patients are intolerant to beta blockers, or a peak VO2 under 50% of the predictive value in patients that are young. Submaximal testing can also be used, and if they have a slope that's over 35, a VCO2 slope that's over 35, being the normal under 34, then it can also be an indication for transplantation. So in summary, this is what we can infer from a cardiopulmonary testing. So we look at the peak VO2. If it's, let's go on the right side, if it's low, then did we reach anaerobic threshold? Was the anaerobic threshold normal? So after 40% of the peak VO2, so at a normal stage, then it's probably a breathing reserve. If the anaerobic threshold was early, then we look at the breathing reserve, we look at to see if it's low or if it's normal. And if it's normal, then we could attribute that everything is related to, heart failure. If we keep going on this other side, if the anaerobic threshold was reached normally at the right time, we look at the breathing reserve. If it's low, then there might be a ventilatory impairment. And if the breathing reserve was normal, maybe we can think that this could be deconditioning or effort, that test was submaximal. So let's look at a couple of cases so we can go over this plot and analyze the information that we got. So on this first case, we have a 57-year-old male with systemic amyloidosis. This patient comes to the office saying that he's had hoarse voice for a long time because he has some vocal cord infiltration and some central airway involvement. As he's been progressively short of breath and having dyspneic exertion to less than 3 blocks over the last year. His exam, his oxygen saturation is 96%, but other than that, his vitals look okay. And there's some stridor on forced inspiration, but otherwise his exam is fine. There's no edema, no crackles. He's on an antihypertensive, his EKG looks normal, and his echo also looks normal. So what do we see here? So on the right side, we have the spirometry, which is also part of the cardiopulmonary stress testing. So we see that the FEV1 is 85% predicted at 4.1. The FVC is 3.1, which is 84% predicted. Anything over 80% is appropriate. FEV1 FVC is 69%, so 0.7. Which is under 1, which is low. The total lung capacity is 88%. The total, the reserve is 1.8, which is 69% predicted, and the DLCO is appropriate. So, and what do we get? The workload that the patient achieved was 170, which is only 70% of predicted. The VO2 max was only 62% of what was predicted. So one, the workload was on the lower end, and the peak VO2 was also low. The VO2 at anaerobic threshold was reached on the early side of what was expected. The ventilatory effort was 68%, was 61%, which is below what was predicted. The breathing reserve was only 43. The saturation remained the same, and the heart rate went from a baseline of 88 to 158. So it reached about 91% predicted. And we see that the spirometry at maximal effort looked like a somewhat obstructive disease with a little curve here. So on the plot, what can we see? So as we go to the first on the left, as the work rate was increasing, His peak VO2 went up somewhat linearly. His heart rate on the third graph on the right, his heart rate went up also linearly, and so did his stroke volume or his O2 pulse, which is the equivalent. But towards the end, it kind of started to plateau. He did switch kind of early on, as we saw in the results, from aerobic to anaerobic threshold, as his oxygen consumption and his VO2, his VVO2 and his VVCO2, cross paths. His tidal volumes and his respiratory rate went up, but his tidal volumes kind of reached some plateau towards the end. His PET CO2, which I like to think of it as the CO2 that remains on an ABG. So as you exercise, you should not retain any CO2. You should be able to exhale all of it. It went down as is what is expected. So that was appropriate. And he didn't desat. Okay. So overall, what was causing his symptoms? So why did this patient with central airway disease have to discontinue exercise? Did he have abnormal ventilatory mechanics? The answer is no, because his PET CO2 went down as we expected. His respiratory went up as we expected. He didn't desat. And his breathing reserve, which was the RV mentioned on the spirometry, was only 43% of what was predicted, which is something good. So when you're exercising, you don't want to utilize all your breathing reserve, because if you reach that means that you can't go any further, that there's no lung left for you to utilize. You don't want to reach that early. So he had normal ventilatory mechanics, so that was not the problem. Did he have chronotropic insufficiency? No, because he actually responded nicely. He went from 88 to 158, and that was 91% of his predicted rate. So that was appropriate. Did he have inotropic insufficiency? We know this by his echo and his O2 pulse, that his echo was normal. So there was no issues with his ejection fraction. His stroke volume increased, and towards the end, we said that in the normal exercise curve, yes, the heart rate can go linear, but the stroke volume reaches certain plateau towards the end. So his inotropic, his inotropy was sufficient. Was he deconditioned? And yes, this is the most likely answer. So he just didn't reach the expected amount of workload. And did he have pulmonary hypertension? The answer is no. He didn't have pulmonary hypertension. He didn't have any, ventilatory issues in terms of his O2 or his CO2 retention at all. So the answer is 4, deconditioned. The second case, this is a 62-year-old female with non-ischemic cardiomyopathy, from chemotherapy with a low ejection fraction, former smoker, and severe COPD. So this patient comes with progressive symptoms of shortness of breath despite maximal therapy. And the exam shows, heart rate in the 80s, blood pressure in the 90s, also sub 95, and some decreased breath sounds, but no rails. Medication, she's on maximal GDMT, which all drugs. The EKG is ascensively paced, and the echo shows an EF of 36% with moderate MR and a large ventricle. So what did this parameter show? The FVC was 75% predicted. The FEV1 was 35% predicted. The FEV1 FVC ratio was 34. The total lung capacity was 4.5, which was over 100% predicted. The reserve, the maximal reserve, was 2.3, which was 140 of predicted. So this patient did reach his maximal reserve. And the DLCO was low, which is the ability of gas exchange. So this is abnormal already. So let's look at the graph. At the plot. Oh, looking at the results first. So this patient reached only 37% of predicted workload. The VO2 was low at only 70% of predicted. The anaerobic threshold was reached close to where she was supposed to. So she tried based on this. The ventilatory effort was 96% of predicted. So this patient really tried as much in terms of his breathing capacity to get to the maximal point of exercise. The breathing sir was 100, utilized everything in this capacity, in her respiratory capacity to do this test. And the saturation remained about the same, and the heart rate didn't respond as well. So let's look at the plot. So the VO2 went up incrementally as the work rate went up, which is appropriate. The heart rate went up, but with somewhat a blunted response towards in the like mid-exercise, so to speak. So there might be some chronotropic incompetency. But the O2 pulse went up appropriately and increased linearly as it should be. Here, the patient didn't cross over the curves of CO2 versus O2. The patient here increases respiratory rate. The tidal volumes were sort of blunted too. The PET CO2 actually went up when this should not be the case. So that means that there's a problem in the lung here if you're retaining CO2. And there was some oscillation, some desaturation across the chest. So why did this patient stop the exercise? Was it at submaximal effort? Did this patient reach the RER that we expect of 1/1? The answer is she didn't. But was this submaximal? No, because she utilized her whole breathing reserve. So this was her maximal effort, even though the RER of 1, so to speak, wasn't reached. Was this patient deconditioned? No, we saw that she even started retaining CO2. So there was no deconditioning here. There was a limitation in the test. Is this both COPD and cardiomyopathy? Is this just the cardiomyopathy or is it just the COPD? So we have to try to differentiate here. What was the main component? So was the O2 pulse compromised? No, that wasn't the case. It was the heart rate, but the O2 pulse overall looked okay. So if anything, she utilized her breathing reserve completely with a desaturation, with CO2 retention. So the driver of this abnormal test is probably her COPD. And that's all I have for now. Thank you.
Well, thank you so much, Dr. Chavez. That was such a highly informational talk. I'm not sure if there's any questions out there from the group. I'll just wait for just a moment. I know we ran a but that's quite okay because I think there's so much very valuable information that was provided. So if there's no questions for today, Patricia, thanks again for putting that together for us. I think I can say that you're going to be our local CPET expert, and and I'll be relying on you for some questions in the future. So it's fantastic to have you on board. So
Thank you so much, guys.
talk to you soon.
Bye.